From Microbe TV, this is TWiP, This Week in Parasitism, episode 215, recorded on March 23rd, 2023. I'm Vincent Racaniello, and joining me tonight from Fort Lee, New Jersey, Dixon Despommier.
Hi, y'all.
Oh, my gosh.
I thought I just... Hey, I was born in New Orleans. I can say that.
You don't really have much of a Southern accent.
I have no accent whatsoever.
How would a New Orleans accent go, Dixon?
This is how... They talk with a funny accent when it comes to things like the word work. They won't say work; they'll say woik.
Woik. Sounds like a Brooklyn
woik.
accent.
And they love to say woik. They have a lot in common with the people from Brooklyn. They really do. They at least with their word choices and their
a lot
word
of
phrases.
Influence of Creole on their speaking as well, right?
Yeah, that's right.
Little
exactly
French accent.
Right.
All right. Also joining us from New York, Daniel Griffin.
Hello, everyone.
You don't have an accent either, right?
You know what's funny, Vincent, is I actually grew up with a New York accent. And I really, I really worked hard to get rid of it. And there was a point when I would get tired, it would occasionally come out. And my parents actually had pretty much lost their accents too. But I still remember being in college, and my roommates would make fun of me because my mom would leave a message on the answering service. Daniel, it's your mother calling. I'm like, mudda. Yeah. Actually, no. It's a TH. There's an R. There's all kinds of problems with that, Mom.
Right. Also joining us from Glasgow, Christina Naula.
Who has no accent whatsoever.
Hello, everybody. I was going to say I've probably got the strongest accent.
What kind of accent is it, would you say?
Yeah. I think it's probably Swiss German with a little bit of west of Scotland. I don't know. It's difficult to judge your own accent, isn't it?
I hear Scottish in your accent. Nothing else, but you grew up in the other place, so that makes sense. Yeah.
The other place.
When I was first visiting Christina, we went for a bit of a hike with her boys, and I still remember when one of them said, "Mommy, why does he speak so funny?" And I was like, "It's not me that's speaking so funny."
Christina, what did you say to that?
It's us. I probably said something like, "Don't be rude."
This is not that funny.
All right, let's get into our case from last time. Daniel, you remind us what we have here.
Sure. For those of you tuning in for the first time, or for many people tuning back in, the case from TWiP 214 was still in Uganda, but now we were at a clinic in Tsetse. This was a young lad, less than age 10, who grew up in very limited resource setting, dirt floor at home, number of other siblings, and he presented with recurrent right upper quadrant abdominal pain, fevers. You have several of these episodes. He undergoes some blood work that shows eosinophilia, so elevated eosinophils. And this story prompts them to perform an abdominal ultrasound, which shows what looks like a mobile piece of spaghetti in the gallbladder with dilated ducts. I didn't tell you what type of spaghetti, but he also has a stool examination performed. And so I felt like that was plenty of information.
All right, we have a good number of guesses. Dixon, can you start for us?
I certainly can, or as they say in Brooklyn, I certainly can. Derek writes, "This is Derek. Glad I got last week's case study correct with the case of hematuria. Before diving into this case study, I have a quick question for the panel. How do microparasites avoid infection from viruses or bacteria?" I'll stop right there and say they don't. Maybe it would be more helpful to narrow the focus on schistosomes. I'm curious because after going over all the structure of these parasites and many others, there doesn't seem to be any structure dedicated acting as an immune system. With that out of the way, on to the case. I'd like to first break down the details to have an idea as to what I should be looking for. To make this a little more challenging, I'm going to rely on Color Atlas of Parasitology and my own undergrad notes for the most part. The following stands out to me. Morphology, mobile piece of spaghetti. Tells me we're looking at a cestode or nematode / acanthocephalans. Eosinophilia supports this assumption. Target organ. Assuming the parasite hasn't gotten lost, target organ is likely the bile ducts of the liver. Secondary possibility are the duodenum, upper regions of the small intestine or stomach. Maybe even the gallbladder, but I haven't heard of a parasite that targets that region as of yet, given that I'm still taking an introductory course. Well, you'll get to it, my boy. This pathogen also likely has a terrestrial life cycle. Initially, I eliminated cestodes. Most of them target the small intestine, and I'm looking more specifically at parasites that target the liver, bile ducts, duodenum, or duodenum, as depends on how you pronounce that, or gallbladder. If nematodes don't give me anything that's specific, we move back to cestodes. Additionally, the case study does not mention the ingestion of raw / undercooked meats, which seems to be the most common way cestodes infect humans from my understanding. The most likely culprit from my Color Atlas of Parasitology is Capillaria hepatica, as the rest seem to target the small intestine / colon or even migrate to the lungs, which seems irrelevant to this case. First, let's check the region. A Google search of Capillaria hepatica in Uganda yields nothing. This parasite seems not to be endemic anywhere and is rarely found in humans. I looked into the symptoms of this nematode, though, and they seem to fit. Hepatitis, fever, eosinophilia. While it seems like a long shot in an epidemiological sense, I'm going to stick with Capillaria hepatica due to the fact that the symptoms and life cycle of this parasite seem to fit this case the best. Google did suggest Ascaris lumbricoides, but I'd like to put that in parentheses, but what does Google know? As a likely culprit, though this parasite infecting the bile ducts seems to be the result of it being lost. Ascariasis does also seem to be much more common. So Ascariasis is going to be my secondary honorable mention. And it seems to me that a lot of tests, such as stool samples and blood tests, would be inconclusive as to the differentiation of the two. They don't seem very morphologically different. I'd love to hear about how the TWiP team can tell these two infections apart, and you will. In either case, albendazole seems to be a good treatment for both parasites.
What was I going to say here? I wanted to say something very clever. And now I've forgotten.
Come on, Vincent, you can do it.
All right, we'll have to see if it comes back. Daniel, can you take the next one?
Hawken writes, hello from balmy Athens, Georgia. Currently 77 and sunny here. Having heard last month's case about the boy in Entebbe, my guess would be Ascaris lumbricoides. Given the prevalence of the parasite across Africa, along with the general nutritional deficiencies mentioned in the last episode, this would be a smoking gun. While doing some research to confirm this theory, I came across a paper talking about the high sensitivity ultrasound gives when confirming a diagnosis of Ascaris in the gallbladder, which would explain the moving spaghetti. Other ideas I tossed around was an individual from Southeast Asia who moved to Entebbe with clonorchis or a nasty case of Diphyllobothrium. Ultimately, Occam's razor had me settle on Ascaris lumbricoides. Treatment would be an anti-helminthic drug, perhaps ivermectin, or if necessary, a cholecystectomy. Looking forward to your next episode. All the best, Hawken.
Christina.
Marcus writes, Dear unholy Trinity and Dixon, much like schistosomes, ye are far too delightful to ever be unholy. On time again. This time I may ramble on a bit, if you will indulge me. Here at 63, sorry, my microphone seems to be crackling a bit. Here at 63.5 degrees north, the sun has been peeking out from behind the mountains again. Though I look forward to spring, this also means the sunlight reveals all the dirt we have collected over the winter. This meant I was cleaning the kitchen during my first listen of this month's case and was a bit distracted. All I heard was something about right upper quadrant pain and ultrasound, which had me thinking, pipe steam fibrosis, schistosomiasis again. Brilliant plan, doing precisely what we've done 18 times before. Is exactly the last thing they'll expect us to do this time. See, Blackadder goes fourth, and they give us a link to a YouTube video. But no, there was a wiggly worm there. In medical school, there is an axiom that often proves true. 80 to 95% of diagnoses can be made on history alone. The exact number varies with the lecturer's confidence in their own brilliance. So I went back to the start and listened. There's a young boy living on a dirt floor. Now, in the same way that freshwater swimming makes me think schistosoma, I have near Pavlovian response to the word dirt floor and shout the unholy trinity out loud. Not trichuris or ankylostoma now. A visible worm in the gallbladder had me thinking of biliary ascariasis. So let's unpack that a bit. Right upper quadrant pain, fevers, and what sounds like jaundice from Daniel's evasive answer. That would be Charcot's triad for ascending cholangitis, usually caused by a stone. An obstruction would cause biliary stasis, and secondary to that, ascending infection with gut bacteria, biliary colic and jaundice. However, I have never heard of multiple recurring episodes of that, being that it is fatal in 5 to 10% of cases when treated and near 100% when untreated. This being a podcast on parasitism, our patients certainly would have eosinophilic cholecystitis, where Ascaris in the gallbladder is a known etiology, but cholecystitis doesn't cause biliary obstruction on its own. And with jaundice and dilated ducts, there certainly is obstruction there. So what's going on? Now, the most important step in the treatment of cholangitis is removing the obstruction, usually by ERCP. This allows bile to flow freely out of the ampulla vateri, and though we cover with
Amjet, metronidazole,
antibiotics. Okay, thank you. Thank you, Daniel. I just couldn't figure out these abbreviation. It isn't unlikely that source control by removing the obstruction may be enough. So I'm thinking maybe there is some kind of variable obstruction here, either with a ball valve effect or something being passed out in the small bowel. This would explain the periodicity and is the case with Ascaris entering ampulla vateri from the duodenum. Since this typically only happens with a very high worm burden, quite probable with his distended belly, it doesn't seem unlikely that another worm may have made a home in the gallbladder. As for the eosinophilia, it usually denotes helminth migration and tissue invasion and is a common finding in biliary ascariasis. So there we are, biliary ascariasis. The stool exam may show Ascaris eggs and sputum may show larvae. Treatment with paralytic antihelminthics should allow for normal expulsion, and failing that, surgical or endoscopic approaches may be attempted. Keep up the great work. I look forward to each episode. Marcus. P.S. On a slightly different note, would it be rude of me to ask whether you have considered a podcast of a similar format for more general tropical medicine? It isn't like you already have too many projects going on.
All right. I'm not going to answer that. I don't know how we would do it. All right, Leon writes, I'm writing to you from Grenoble, France, where I'm conducting structural research on the unique mechanism of mRNA editing in T. brucei. If you haven't already heard about this fascinating topic, I highly recommend everyone looking into it. I've been a long-time listener of this podcast, and although this is only my second time writing in, I hope to improve and earn a signed copy of the book. All right, that would make you number 4 here. Now, on to the case at hand. The young boy from Uganda is likely suffering from fascioliasis, which is caused by the parasite Fasciola hepatica. The infection cycle typically begins when water plants are contaminated with encysted metacercariae are ingested. Once these little buggers make their way to the small intestine, they hatch and set off on a journey to the liver and bile ducts, causing inflammation, blockage, and dilation of the bile ducts, resulting in abdominal pain, fever, and eosinophilia. The mobile piece of spaghetti seen on imaging is likely the adult parasite, which can grow up to 3 centimeters long and may migrate to the gallbladder. Diagnosis can be made by microscopic identification of eggs in the stool, particularly when adult parasites are present. Treatment of choice, triclobendazole, administered in 2 doses, 10 mg per kg, 12 hours apart in patients of this age. Hope the boy has fully recovered. Best from France. Dixon.
Ben writes, my guess is that the patient is suffering from ascariasis caused by Ascaris lumbricoides. The description matches this other case I found on Google by searching several of the words from the description. The, quotes, right upper quadrant pain, unquotes, was what convinced me. This other case was in Thailand, but Ascaris lumbricoides is found across the tropics and other places too, by the way. That's when Ben, and by the way, he's already won a book.
By the way, now I remembered what I was going to say.
Oh, good.
Because everyone's talking about a Google search. When do you think people will start doing chat GPT searches and putting in that, right? That's going to happen sooner or later. You know what that is, Dixon,
True.
right?
Not a clue.
Seriously, where have you been? Under a rock?
Yep. I have, actually.
All right.
And a hard one,
Daniel.
too.
All right. How shall we pronounce?
Ayal.
Eyal?
Ayal.
Eyal, I asked our Eyal who's providing us with the case. I called him up.
Oh, he's
and
also
asked.
Ayal.
So, yeah, well, it's the same name, so I presume the pronunciation will be the same
So it's
from
like
the Hebrew.
Ayal.
So like you're a Canadian or something?
Yeah.
Eyal.
Yeah.
All right. Dear sages or microscopics eukaryotes, warm greetings from Sydney, Australia, where the temperature is 25 C. I'm writing to you on the 3rd of March, which is also the 3rd day of autumn. I guess in Australia, the seasons start on the 1st of the month, as we don't really have different seasons anyway. First, with regard to last month's case, boy, was I wrong. Luckily, the gentleman had a very competent physician and not an uneducated computer engineer. Now to the new case, a Ugandan boy, less than 10, with recurrent right upper abdominal pain, fevers, eosinophilia, and a mobile large piece of spaghetti in the gallbladder. I started by trying to understand what intestinal parasites are typical in Ugandan children. Luckily, I found a PubMed article describing exactly that, human intestinal parasites in primary school children in Kampala, Uganda. Going through the list of typical parasites, Trichuris trichura, 28%, Ascaris lumbricoides, 17%, and hookworms, 12.9%, as well as S. mansoni, Strongyloides stercoralis, Tania species, Anaerobius vermicularis, Giardia lamblia, and Amoeba coli, and E. histolytica. Out of the list described in the article, only 2 species are large enough to be described as a piece of spaghetti. Ascaris lumbricoides, a few millimeters in width and 15 to 49 centimeters with an E in length. Centimeters, I think is how he's pronouncing that, by the way. Definitely within the spaghetti size range. Taenia saginata, normally 4 to 10 meters in length, but could grow up to 22 meters. In my mind, it is more within the range of hand-stretched noodles than spaghetti. With respect to the gallbladder and ducts morphology, I found an analysis of hepatobiliary and pancreatic ascariasis in an endemic area in Kashmir, India. Gives us a link. According to that article, ascariasis is responsible for 1/8 of all biliary lithiasis cases. Based on the symptoms, prevalence, and size, my guess would be Ascaris lumbricoides, treatment 1 to 3 days of albendazole or mebendazole for him and his close contacts. For prevention, human feces should be properly treated.
Okay, Christina.
Mark writes, hey TWiPers, I was chatting about this episode's case history online at another website. Here's our joint work. Differential diagnosis, gallstones. Gallstones can cause similar symptoms as gallbladder ascariasis, including recurrent abdominal pain and fever. However, the presence of eosinophilia would not be expected in this condition, and the ultrasound findings would be different from those seen in gallbladder ascariasis. Cholecystitis. Inflammation of the gallbladder, called cholecystitis, can also cause right upper abdominal pain and fever. However, eosinophilia would not typically be present, and the ultrasound findings may show thickening of the gallbladder wall rather than a mobile structure. Hepatitis. Viral hepatitis can cause abdominal pain, fever, and elevated liver enzymes, but typically would not cause eosinophilia or the ultrasound findings seen in this case. Parasitic infections. Parasites such as Ascaris lumbricoides, liver flukes, or giardiasis may also cause similar symptoms. If flukes or giardia, then the ultrasound findings and eosinophilia would be different. To confirm Ascaris lumbricoides as the cause, search for eggs in the stool of the sick boy. Their presence would indicate Ascaris lumbricoides as a cause. Diagnosis. The description is suggestive of gallbladder ascariasis caused by the roundworm Ascaris lumbricoides. This parasite is common in areas with poor sanitation and hygiene practices and is often transmitted by ingesting contaminated food or water. In this case, the presence of eosinophilia in the blood, along with the finding of a mobile piece of spaghetti-like structure in the gallbladder on ultrasound, strongly suggests the diagnosis of gallbladder ascariasis. The dilated bile ducts may indicate obstruction caused by the parasite, leading to recurrent abdominal pain and fever. Treatment for this condition typically involves medication to kill the parasite, such as albendazole or mebendazole, and supportive care to manage symptoms and prevent complications. If this diagnosis is correct, then I pass on entering the raffle for a copy of Parasitic Diseases, 7th edition. My PDF copy is 197 megabytes and is way smaller and lighter than a 602-page hardbound tome. Mark.
Yeah, but it's autographed, man.
I was going to say it's not signed.
Christina, could you just move your mic down like an inch so you don't get the popping?
Yes.
Good. Thank you very much. Christopher writes, this is likely a case of an overly adventurous Ascaris lumbricoides worm that decided to go spelunking up the ampulla of Vater, which is the orifice out of which products of the pancreas and bile duct are dumped into the duodenum. The nematode likely traveled up to the gallbladder with some intestinal hitchhikers like gram-negative bacteria, which are causing cholecystitis and also inflammation of the gallbladder. It could also have caused physical bile duct blockage, which predisposed the patient to the infection. I wonder if, similar to strongyloidiasis hyperinfection, an overt gram-negative anaerobic bacterial infection will override the eosinophilia and cause bandemia instead. Daniel, what's bandemia?
Yes, actually, great, Christopher. So bandemia are when a person is responding to some sort of a stimuli that's causing the generation of white blood cells, particularly neutrophils. Before the cells become polysegmented, so PMNs, really, polysegmented neutrophils, they'll actually start off with just a band of nuclear material. So they're early neutrophil forms, and we call them bands. And a lot of times when someone is septic, has an acute bacterial infection, you'll see an elevated percent of bands. It might be 1 or 2% normally, but this might go up to 9, 10, 20%. Actually, I have a patient today, 9% bandemia. And when that happens, when a person gets septic like that, you'll get eosinopenia. The eosinophils will clear, and you'll see elevated bands.
Wow. Dixon, you are next, please.
I am, yes. Joseph writes, hello, TWiP professors. It's a comfortable 70 degrees Fahrenheit with clear skies here in Charleston, South Carolina. South Carolina, that's how they say that down there. I wouldn't dare say that up here. I believe that I won't go on. I believe that the young boy with recurrent right upper quadrant pain, fevers, and a spaghetti-like abnormality on abdominal ultrasound has gallbladder ascariasis resulting from infection with Ascaris lumbricoides. When thinking about the gallbladder and potential parasites, my mind immediately went to the liver fluke Clonorchus sinensis. However, this parasite is endemic to Asia rather than Africa, and the adults are shaped more like orzo rather than the spaghetti. The extra hints of limited living conditions / dirt floors, abdominal distension, and stunted growth led me to conclude that Ascaris lumbricoides is the causative pathogen for the patient's symptoms. Wouldn't be surprised if further abdominal ultrasound revealed even more helminths residing in the boy's small intestine, which are responsible for the distension and stunted growth. A worm migrating from the small intestine through the hepatobiliary tract could have gotten stuck in the patient's gallbladder and led to the recurrent RUQ pain and
Right upper quadrant.
Right upper quadrant, that's true. Ascaris infection can also be asymptomatic, which could explain the lack of symptoms among the boy's multiple siblings. There are no serologic tests available for Ascaris. However, the presence of large, thick-walled eggs in the patient's stool exam would support this diagnosis. Treatment could consist of albendazole or mebendazole, both of which kill worms by inhibiting microtubule synthesis. Good on you. Ultimately, surgical removal of the gallbladder may be necessary if the debris from the dead worm blocks the bile duct and leads to cholecystitis. Should the siblings be presumed to have asymptomatic infections as treated as well? Thank you for all you do. Joseph.
Daniel.
Kevin writes, it's a chilly, overcast, but enjoyable 46 degrees Fahrenheit, 8-ish degrees Celsius here in beautiful St. Louis. I recently finished the latest episode of TWiP while walking my dog this afternoon and decided to write in finally after having been a long-time listener. With regards to the boy in Entebbe presenting with right upper abdominal pain, fevers, and eosinophilia, my suspicion is that this is a case of hepatobiliary ascariasis, HPA, due to parasitic infection by the intestinal helminth Ascaris lumbricoides. The incidence of Ascaris infection is high in rural, subtropical, tropical regions where sanitation is limited, which provides further support in this case. In addition to the ultrasound findings, and that children tend to present with hepatobiliary symptoms more than adults with Ascaris infection, the spaghetti finding also suggests that the boy's condition is due to a high worm load and that there has been migration into the hepatobiliary tree, indicating a possible medical emergency. The ultrasound findings may be sufficient to diagnose HPA, but a stool sample is typically used to confirm the presence of the hardy Ascaris eggs in less severe presentations of infection. I suspect this is what we will see, but one source says that stool examination may have little diagnostic value in endemic areas with presentations of HPA. Albendazole and mebendazole are sufficient treatments for most cases of Ascaris infection and should be started, but due to the severity of symptoms here, I would suspect that surgical intervention will be required additionally, as this seems to be a case of biliary or intestinal obstruction. Looking forward to more episodes. Sincerely, Kevin, and we get some links.
Christina.
Daniel writes, greetings TWiP team from sunny South Africa. My name is Daniel. It is a lazy, warm, clear day in Johannesburg. I'm intrigued by the case of the 10-year-old boy in Entebbe, Uganda. On searching for parasites which can invade the hepatobiliary system and can be visualized by sonography, I came across several articles which describe sonographic findings of ascariasis and fascioliasis. In an article by Elapsi et al. Entitled Biliary Ascariasis, the Value of Ultrasound in the Diagnosis and Management, the authors state that the worms are often seen as one or more non-shadowing tube-like echoic structures, which may be straight or coiled. Overlapping coiled or aggregates of worms may have an appearance like spaghetti. Dilatation of the common bile duct with or without a distended gallbladder is the next common finding. These sonographic features seem to match the findings in the young boy from Entebbe, whose sonar reveals what looks like a mobile piece of spaghetti in the gallbladder with dilated ducts. An article by Richter et al. Entitled Fascioliasis, Sonographic Abnormalities of the Biliary Tract and Evolution After Treatment with Triclobendazole, describes the parasite Fasciola hepatica as appearing crescent-shaped on sonar. According to this article, dilated hepatic ducts can also be present with infection with this organism. Ascaris lumbricoides and Fasciola hepatica and Fasciola gigantica have a wide distribution, including being found in Africa. Both can cause the recurrent abdominal pain, fever, and eosinophilia seen in the patient. Ova from both organisms can be found on stool microscopy. The ova for Fasciola species may be minimal or absent in acute infections or when there is low parasite burden, so multiple stool samples may be required. If immunological tests are available, these may be valuable in making that diagnosis of fascioliasis. There's also the possibility of co-infection with both Ascaris and fasciola. Given that the sonographic findings seem more in keeping with Ascaris lumbricoides, Ascaris infection is my guess. Thank you all for your entertaining and fascinating podcasts. Kind regards, Daniel. And he gives us the links to the articles he mentions in his email.
Daniel, we can't have your guess. I'm sorry.
That's a different Daniel.
Oh. Michelle and Alexander from the First Vienna Parasitology Passion Club write, Dear Lumbry co-hosts, case of the young boy with biliary colic is easy to narrow down by considering the visualization of the parasites within the lumen of the gallbladder. By also taking into account the geography, the dirt floor home, and prevalence, we believe we can come to a diagnosis with a good degree of certainty. While a number of helminths can invade the liver, in their life cycle, only a small number can be visualized by ultrasound within the biliary duct, Clonorchus sinensis and Opisthorchus vivarini. While the adult flukes can sometimes be visualized in the gallbladder, they do not grow much beyond the length of 15 millimeters, resembling farfaline rather than spaghetti. Both of these species are not commonly found in Uganda. Fasciola species, while the adults of F. hepatica can grow up to penny size. Dixon, you know what a penny is? It looks like a ziti.
Like penne alla vodka?
Yeah, it looks like a ziti. The morphology is not consistent with twirlable pasta, while fasciola species are prevalent in cattle in Uganda. A quick search did not yield any report of zoonotic transmission to humans in the country. Ascaris lumbricoides, the worm, is morphologically, though not likely culinarily, similar to spaghetti. It is also one of the most common helminthic infections in resource-limited regions and is often responsible for growth stunting, especially when co-infections with trichuris or hookworm species are present. As a soil-transmitted helminth, the parasite is acquired by exposure of the bare skin, mostly the feet, to soil contaminated with the larvae. Stool examination should reveal the eggs of A. lumbricoides. The sample should also be examined carefully for the presence of other soil-transmitted helminths. Treatment with a single dose of albendazole or ivermectin should be sufficient. The most important steps to prevent reinfection are effective waste disposal and wearing shoes when walking on soil. Both require resources often lacking in rural areas. Thanks for this great case. Dixon.
Martha writes, Dear TWIPsters all, I always enjoy episodes of TWiP and have always learned something from researching the problem. I listen intently to the case presentation for hints. Surely I was not the only person yelling at the screen, "It's vermicelli!" when Dr. Dupamier asked what sort of spaghetti was in the gallbladder. My research was not vermicelli. In the U.S., vermicelli is thinner than ordinary spaghetti at 1.5 millimeters in diameter. In Italy, vermicelli is thicker than spaghetti at 1.2 to 2.3 millimeters in diameter. However, the adult male Ascaris lumbricoides has a diameter of 2 to 4 millimeters, so that the pasta most closely resembling it would be bucatini. Did I say that correctly, Vincent?
Bucatini.
A bucatini, with a diameter of 3 millimeters, with a hollow interior similar to the worm's gut. I had no idea. I'm going to go out and buy some after this show. Of course, the question is not what sort of pasta most resembles the parasite, but what should be done for this patient. It is known that A. lumbricoides will enter the bile ducts and gallbladder. This is more likely to occur if there's a heavy parasitic burden, which is hinted at by the remark that the child's abdomen is distended. This can result in a right upper quadrant pain, acalculous cholecystitis, jaundice, and pancreatitis. Although his siblings are without similar complaints, they may well harbor A. lumbricoides, as the infection can be relatively asymptomatic. Treatment depends on how ill this child is. If the child is stable enough, then a trial of conservative management could be attempted. This would involve observation while the child is given IV hydration, an anti-helminthic agent, and kept NPO. What is that one?
Nothing per os, so you're not allowed to have anything per mouth.
Very good. While awaiting expulsion of the worm from the gallbladder, Should conservative management not succeed, then, if available, attempt ERCP, endoscopic retrograde cholangiopancreatography, for extraction of the worm. Cholecystectomy is more invasive but will prevent recurrent episodes. Yeah, in the gallbladder because it won't be there, but it won't. Since I suspect other family members are also infected, I would suggest testing and treating them as well. I look forward to the next episode. Best wishes to all.
Daniel, one of these days we should have you tell us all these
all these
abbreviations,
terms of art, all the TLAs, 3-letter acronyms.
Yeah.
It's really
we'll make up
amazing.
different words for each one.
Yeah.
like there's one for how many times a day you get a drug, right?
TID.
TDR.
What does that mean? What does that quote stand for? TID?
TID. It's really interesting because if you actually go back to like what's the derivation, right? So once a day used to be QD, but now we say daily to avoid confusion. Twice a day would be BID. TID 3 times per day. QID 4 times per day.
Cool.
Yeah.
Wow.
Et cetera, et cetera.
And it's actually, it all goes back to Latin. So yeah.
Right.
Daniel, you're next.
All right. Kimona writes, Dear TWiP team, the tubular... I'm getting hungry, actually, I have to say. And I want pasta now.
I don't blame you.
The tubular-shaped pasta product seen in the gallbladder of this young boy in ultrasound could be a case of hepatobiliary ascariasis. Ascaris lumbricoides is a non-segmented roundworm belonging to the phylum Nematoda. Eggs are ingested, hatch in the small intestine, and the larvae travel in the circulation to the lungs, where they ascend the bronchial tree and are again swallowed, usually ending up in the jejunum. Here they mature, find a mate, and females can shed, deep breath, about 200,000 eggs per day, making it likely that eggs were seen on this boy's stool exam. Large worm burden is more prevalent in children, likely from continuous reinfections, and their sheer bulk can lead to intestinal obstruction. This bulk is also believed to alter gut motility, now locating the worms further proximally in the duodenum, where they have a natural inclination to seek out small orifices. Any type of stressor, such as a simple fever, may trigger migration into one of the duct's orifices of the biliary tree. Treatment of hepatobiliary ascariasis may involve albendazole or mebendazole, the former often used in school deworming programs. Once a worm migrates into a duct such as the common bile duct, it can cause symptoms of intermittent biliary colic as it blocks the cystic duct. The boy's right upper quadrant pain was recurrent, possibly suggesting this. Treatment seems to vary from simply waiting for the worm to exit, giving a vermicidal, or using antibiotics and endoscopy or surgery, especially if there is any sign of acute cholecystitis, such as this boy's fever. A few articles referenced concern that vermicidals may kill the worm, but may render it stuck within the biliary tree. Gallbladder ascariasis, as in this boy, is less common than bile duct ascariasis and seems often to necessitate cholecystectomy. I also found reference to a female-to-male ratio of 3-to-1 for hepatobiliary ascariasis, as well as a decreased incidence in children, possibly due to the small caliber of their biliary system. Perhaps this young boy's presentation is a bit unusual. Staring gloomily out the window at over 3 feet of fresh snow, it just doesn't seem fair. Warm regards, Kimona.
What's wrong with snow? Kimona's up in Vermont, right? That's what you do in Vermont. You get snow. Huh. All right, Christina.
University of Central Lancashire Parasitology Club writes, Dear Professor, Easter greetings from the University of Central Lancashire Parasitology Club in the wonderful northwest of Britain. The weather cannot make its mind up. We have had snow for 2 days and then sunshine the next day. However, in Britain, we are used to such strange weather. We have 3 soil-transmitted helminth in our differential diagnosis. Ascaris lumbricoides, the roundworm, Trichuris decura, the whipworm, and Ankylostoma duodenale, the hookworm, which are a common cause of morbidity in Ugandan children. Trichuris trichura, the human whipworm, could be a possibility based on the living conditions, and eosinophilia is commonly seen in people with whipworm infection. However, infection is typically associated with chronic and persistent diarrhea, which is not in the patient history. Hookworm infection is predominantly marked by iron deficiency anemia. Both whipworms and hookworms are quite slender, between 1 to 3 centimeters in length, and may not be visible on ultrasound examination. We believe that this boy is heavily infected with Ascaris lumbricoides through repeated ingestion of ova via the fecal-oral route due to poor domestic sanitation and likely little access to clean water for washing produce. According to DAS 2014, larval invasion of blood leads to increase in peripheral eosinophilia, and stool examination is often carried out to detect Ascaris eggs. Adult ascarid worms measure between 13 to 18 centimeters in length and perhaps more likely resemble spaghetti on ultrasound imaging. I'd just like to stop. I'd kind of think it would be more udon noodles. I've been thinking about udon noodles while reading all these emails. Because they're a bit thicker, aren't they? Yeah. Anyway, thank you again for this interesting case about a boy with a spaghetti-like structure in his belly, and we hope that our letter does not arrive past the date to be read on the next show. David, on behalf of the Parasitology Club of the University of Central Lancashire, and there's quite a list of references, including including the 7th edition Parasitic Diseases paper, textbook. Sorry, my brain's switching off. It's late.
All right, it's our last one is from Jason. It's a cool 7 degrees C in Seattle as I put pen to paper on the TWiP 214 case study for our Ugandan patient. It would seem that all roads point toward infection with Ascaris lumbricoides, the giant intestinal roundworm. While this nematode usually dwells in the intestinal lumen, it's not unheard of it for it to present ectopically in locations such as the gallbladder. The adult stages of this widespread geohelminth are large enough to appear on ultrasound, as they do in this case, and the stunted growth of the child coupled with eosinophilia makes a strong case for a presumptive diagnosis of Ascariasis. The next step would be to obtain laboratory confirmation via a stool, ova, and parasite exam, followed by treatment with albendazole or mebendazole. Worm regards from Jason. And that'll do it.
All right, some good guesses. Lots of emails this week.
Yeah, we had a good one here. It's a good.
I say this week, but we all know this month. But this week in parasitism.
That's right.
All right.
That's WEAK.
Well, wait, before we give away this book, Dixon, did you have an idea? What do you think's going on? What kind of
it's
pasta
a total
do you think?
mystery. You stumped me on this one there, big guy. No, to be honest, I nailed that one pretty well at the start of your description of what his living conditions alone was enough to convince me that a spaghetti, I probably would have used a different term, but that would have given it away, because I usually referred to it as a pen-size organism. In case you're all wondering out there to medical students what these things actually look like, the item that you're writing these notes down with, that's about the size of this worm. And then once they look at the worm, they all drop their pens, as if that was the worm. But yeah, so Ascaris is the absolute right idea. The other thing that occurs is that some of the guesses, at least, indicated that when the worm gets into the gallbladder and jams it all up, then the fever starts. He's probably had a fever from something else to begin with, which caused the worm itself to actually migrate. So that's usually true for pre-adult children of various ages, usually between the ages of 3 and 5. Imagine, for instance, how many people in malaria outbreaks in Central Africa would be of that age group and also harbor Ascaris. And it must be very common for these worms to migrate, and you can reach temperatures of 104, 105 degrees Fahrenheit. That's plenty of temperature to get this worm to try to escape, so to speak. Some worms actually do escape. They actually crawl out the anus and go. But other worms make it all the way up to the oropharyngeal region, and that's very unnerving to a doctor, let's say at Columbia Presbyterian Hospital, which I know actually it occurred once. A third-year student made the diagnosis after they had to pick the doctor up off the floor because he fainted almost, and this third-year student brought the worm down to the lab, and oh yeah, that's Ascaris. Where'd you get it? Well, it came out of the nose of a small child that we've got as a patient here from Central Africa, or else, right? Lots of other places, of course, and that's the disadvantage of never having this subject in medical school, is that you think you're prepared for everything, but you ain't seen nothing yet. Parasites can really gross you out sometimes, and this is one of those that can actually do that.
Yeah, and entertaining communication. While I was, it's off in Phoenix for a week, and one of our pediatricians had a young teenager who had been in Costa Rica quite a bit previously. I think that's important, and had come in and actually a couple pen-size worms had actually exited the anus while they're in the pediatrician's office.
Wow,
so he's
really?
He's on the phone with one of my partners. I'm looking at them. I can see them. They're the size of a pen. There's two of them right here. What should I do?
That's right.
Wow.
All right. Well, before we confirm or deny, Christina, what were you thinking?
I'm thinking I'm glad I've had my dinner already. I did actually think a 10-year-old boy, dirt floors. I did think of soil transmitted helminth, and then I had a cheeky Google. Google's actually quite good, and I Googled ultrasound spaghetti gallbladder, and there's some pictures coming up with hepatobiliary ascariasis, and it does look a little bit like spaghetti, or udon noodles. So I think probably not a very medical diagnosis, but I'm in agreement.
The most astounding radiogram I ever saw, and I saw a lot of them because they would bring them to me and say, Doc, what do you think this is? Because they themselves did not have any ideas at that point with regards to these worms, at least. This patient had ascariasis, and they diagnosed it after they gave the patient a barium enema and a barium swallow to try to find out whether there's anything, wrong with his digestive tract. And the fact is that once the barium cleared, all of the intestinal tracts of Ascaris retained the barium. And they got a barium swallow X-ray of the worms themselves.
Wow.
And to see them, everyone knew what they were looking at, and there was a bolus of worm, and it was just quite amazing, actually. It was quite astounding to see that.
Cool.
You don't forget things like that.
Cool.
Vincent, what are you thinking?
So I'm thinking Ascaris also, because last week I was at APHL, Association of Public Health Laboratories meeting in Atlanta, and I met my friend Ryan, who is a clinical lab director at the Indiana University hospitals, and he gave me a bunch of pictures of stuff that he's seen, and he said, "Show this to Dixon and everybody." And so I just put a picture in the show notes of what he gave me. This is a worm he found in the bile duct of a patient. Or not, he didn't find it, but the doctors found it, and he's got it there on a piece of paper, and it looks like a piece of spaghetti to me.
Well, so
except it's tapered.
Just to interrupt
it's tapered.
Again.
Really, spaghetti is not tapered. Okay.
It is it's not tapered. But the picture of the century, perhaps, of Ascaris was given to me by somebody in Bangladesh.
Yeah.
And it's on our website because of Parasites Without Borders. You can actually download all the lectures that we give. And the Ascaris lecture has a picture of this bell jar that must be a 50-gallon bell jar filled with Ascaris.
Cool. Yeah.
And the director of the laboratory said that was one day's collection from a village that we went out to. Mm-hmm. One day.
Amazing.
It was astounding, absolutely astounding. Now, each worm, right, can produce 200,000 eggs, but not all those worms are females, of course. Only half. So that's, it's only about, guess the number of worms in this jar and get a free sample of thiobendazole to last for the rest of your life or something like that. But it was quite amazing to see this jug full of worms, basically. And that's what we call a jug of worms.
Yeah. Yeah. So, I this story, I think, is, you basically give away with the history. What is it? 95% of the, and a lot of it is what was the size. I mean, I think what maybe people don't appreciate is the gallbladder can be pretty big. Mm-hmm. A distended gallbladder is pretty large. So, it's not large enough for the worm to be completely, stretched out. So the worms, will be wrapped onto themselves. But yeah, probably tapered udon noodles is probably, the right sort of pasta reference for the size of this. So, now the interesting thing is how do you approach this, right? And I think, one of our emailers wrote in, like, how useful is getting that stool sample, right? I mean, it's nice to get stool sample, nice to see those Ascaris eggs. This tends to be in the context of pretty heavily infected individual. So you're going to find the eggs. But then again, you're going to find eggs a lot in this context, so that's one thing. Can you get away with treating these individuals just with, maybe 3 days of albendazole? In a lot of situations like this, that actually is going to be fairly typical. I think if this person showed up here in the States, they probably would end up with the gallbladder out. They'd end up on broad-spectrum antibiotics. It would be approached quite differently. I'm not sure the mortality is as high as it's suggested because there clearly is a syndrome of recurrent obstruction here, which I think is what was presenting with this boy. So, So, I think
it'd be good to mention, Daniel, the sequelae, if you don't treat, in many cases, goes on to a liver involvement rather than a gallbladder involvement, and that could prove fatal.
Yeah.
So, you should obviously treat this right away. It's just obviously right away.
All right.
So he turned out okay, Daniel?
So I don't have much follow-up on this lad because I was right there. They were very excited to share this case with me, and I was flying out the next day. So
nice picture.
Yeah.
All right. All right, it's time for a couple of papers, right?
I know you're going to give away a book, though, aren't you?
Got to give away a book first.
Oh, that's right. We have to give away a book. I was just influenced by Mark there, who didn't want a book, I guess.
No, too bad, Mark.
He doesn't want the big, heavy paperweight. He prefers the electronic.
We have 11 guesses who are eligible. Many people already have books, or they should. I haven't sent them out yet, but let's pick a random number. Dixon, are you ready?
I'm ready.
Number 5. I don't cheat. I actually do the first number that comes up. You think I might cheat, but number 5 is where is number 5? There is no number 5. I skipped it.
No. Go back and renumber.
I can renumber. So number 5 is, let's see, there's number 2 is Hawkin. Number 3 is Marcus. Number 4 is Leon. So number 5 is Yosef.
I guess Yosef becomes
Yosef. Okay, Yosef
from Charleston, South Carolina. I just have a feeling, Dixon, Yosef is not going to have a Southern accent. What do you think?
No, but if he stays long enough, he might develop one like Christina.
He's an MD PhD candidate, so he may be down there for a while. Sorry.
That's right.
Look at that. Medical University of South Carolina, where my twin colleague Michael Schmidt is from.
I was just thinking that.
So
you should go say hi.
Cool. And so anyway, Yosef, send us your address, TWiP@microbe.tv. We will get you out a book within the next 100 years. All right, now
we're getting flippant. I think we should
got to get those books out there. All right, now we've got some great articles, right?
We do.
All right, why don't you go first, Christina?
Okay, so we've had a couple of schistosomiasis cases on TWiP lately, and I thought I'd like to discuss a form of schistosomiasis that is not talked about much and is considered a neglected manifestation of the disease, and that's female genital schistosomiasis, which is a manifestation of urogenital schistosomiasis caused by Schistosoma hematobium. Is my microphone doing that funny thing again? It's really annoying me a bit. So I've chosen an article published in PLOS Neglected Tropical Diseases, which is an open access journal. So anyone who would like to read a paper can go and look it up and read it and look at the study. So the title of the study is Knowledge, Experiences and Practices of Women Affected by Female Genital Schistosomiasis in Rural Madagascar, a qualitative study on disease perception, health impairment and social impact. So this article was published in November 2022, and it has two joint first authors, Angela Schuster and Bodo Sohandra Randrianna Solo. And I apologize if I pronounced that not right. The corresponding author is Herman Feldmayer. It's an international collaboration with authors and researchers from Germany, Madagascar and Denmark. So female genital schistosomiasis is an important gynecological problem in countries where urogenital schistosomiasis is present, which is in large parts of the African continent. And it's common and causes severe symptoms. So it can affect the ovaries, the fallopian tubes, the uterus, the cervix, vagina, clitoris and vulva, and with inflammation in all the layers of the tissue affected. And that's really caused by an immune reaction to the eggs that are kind of deposited. So the disease presents with symptoms such as pelvic pain, particularly during sexual intercourse, vaginal discharge and bleeding and menstruation disorders. And if it is not treated, it can lead to infertility and pregnancy complications, including, for example, stillbirth or spontaneous abortion, and also ectopic pregnancy. So the disease has a major impact on the physical and sexual health of women and also their social life in the community. There is a good degree of uncertainty about the overall prevalence of female genital schistosomiasis because this depends on the level of endemicity of Schistosoma hematobium, but also on the diagnostic methods that are used. And the numbers range really quite widely from about 15 to 75%, depending on the studies that we look at. In Madagascar, where this current study is set, the prevalence ranges from 15 to 52%, so again, quite a broad range. And we may already see or find, if we were looking, female genital schistosomiasis in prepubertal and adolescent girls. So I think we can agree, based on that introduction, that female genital schistosomiasis on women, that the effect it has on women is considerable, and it remains a neglected disease in the community and healthcare system. And I think as a woman, I can understand maybe why that is. So female sexual health is not a common dinner party conversation topic. And it can be quite difficult to articulate problems surrounding what we maybe summarize as women's problems and these things.
Air quotes.
I don't know what they're called, those signs. Thank you. Thank you, Daniel. Even in healthcare settings. So women and girls in those endemic regions, they are really at great risk to acquire schistosomiasis because of the roles they have in society, because of how household chores are distributed, for example, the laundry and water collections. And in communities where men make decisions for their female partner and girls, women and girls may have limited access to healthcare. And of course, there's stigma associated with women's problems, and that might stop women from disclosing symptoms that are due to female genital schistosomiasis. So we know from other geographic areas, for example, Tanzania and Ghana, that the knowledge about this disease in the communities and also in the healthcare workers is low, and that there's lots of misconception. And this is where this study really comes in. It wants to kind of shed a bit more light on this really serious infection. So this study seeks to learn more about the knowledge and the experiences and practices of women with female genital schistosomiasis. And the research question for this study was, what do women with female genital schistosomiasis in Madagascar know about the disease, and what are their experiences related to it? So Madagascar is quite a populated island with maybe 25 million people, and 60% of those are under the age of 25. So it's a country with a high fertility rate. So I think that the total birth per woman is 3.9 in Madagascar, which kind of compares to the UK, where it is 1.6. So, you know, women have a lot of children. It is a poor country, and it's, from a sociocultural perspective, it's predominantly Christian, with about 85% of people identifying with the Christian faith. However, Christian marriage is not, apparently, according to this study, no longer the norm, and cohabitation and premarital sexual relations are common. So the study is set in a district in the northwest of the island, which is an area which is very highly endemic for Schistosoma hemiotrobium. It is rural, and most people make a living through farming, mostly through rice and cocoa cultivation, chocolate trees. I'm trying to say. Income from cash crops is also supplemented by fishing, and women work in rice fields along rivers and ponds, and water for personal hygiene and drinking water comes from ponds and lakes and rivers. Also, open urination and defecation are common in that area, and the kind of mainstay of control of schistosomiasis is preventive chemotherapy in children. So the research team was composed of female researchers that included 2 local gynecologists that were familiar with the area, and I think that's quite important. And they were supported by midwives and local health workers, but also translators to facilitate communication. So this was a qualitative study, and it is maybe not something that we often have on TWiP, because it's quite different in how it is conducted, but it was embedded in another study, a randomized controlled trial that compared different doses of praziquantel for the treatment of female genital schistosomiasis. So 116 women were invited to participate, and then 76 in the end took part, and they could either participate in a focus group discussion or a private interview. So the choice was theirs, and the interviews were and the focus group discussions were transcribed, translated and analysed. And I'm not going into the detail about the data analysis, but if you are interested in how the researchers decided on categories and coding units, you can check this out in the paper, which, as I said, is open access. So from my limited experience of one interview-based qualitative study that I did myself, the methodology seems sound and fairly standard, but please remember that my research background is really firmly sat within a traditional quantitative biomedical research context. So the analysis included questions about the knowledge of female genital schistosomiasis and experiences and practices. So the knowledge included things like transmission, symptoms, risk factors and prevention. Experiences included impact on work and life, the impact on sexual life and partnerships, as well as fears and feelings. And the practices finally included what coping strategies women had in place and information about care seeking. So I just wanted to give you a very short snapshot of findings that I found quite thought-provoking. For example, the knowledge about how this infection was acquired was not well understood by the women in the study. So some women understood that the infection could be through any part of the body, but others thought that the infection had to occur through the vagina and the urethra. For example, through intravaginal cleansing or while urinating, maybe from a toilet seat or the environment. Other women thought the infection was sexually transmitted, and some women also understood that there might be a long gap between infection and the development of symptoms, maybe acquiring it as children when they were swimming. I thought a very pertinent statement from a woman was, and I'm kind of including a few quotes here, what I know is it is here, it is there, it comes silently, the way it breaks into us, the way we catch it is unremarked. And I think, that's quite a pertinent remark. Many women mentioned that they were working in swampy lowlands and insufficient body hygiene after water contact, that this could be a risk factor for contracting the disease. And for most women, the contact with dirty water and mud in the river, ponds or rice fields caused the infection. Some women thought public toilets and outside defecation would put them at risk of infections, and others thought that previous pregnancies could play a role because those women who already had children were seen as more vulnerable. So quite a spectrum of kind of knowledge of how you acquire disease and how it is transmitted. So moving on to symptoms and signs, some women were not aware of being infected and only learned of their infection through participating in the parent study, during which they were examined and tested. Those women who experienced symptoms described vaginal discharge, pain during urination, radiating through the lower abdomen, and pain during and after intercourse. They also described blood in the urine, and I'll just give you a couple of quotes to kind of give this dry summary, maybe a little bit of context. It is painful and it hurts from the inside, and you don't really know, and it becomes annoying. I've never felt such a sensation, an unusual sensation. It's like if my vagina has become larger, and it's awful. And another woman said, there is a kind of sand inside the vagina, like those little grains inside the body. Women were also aware that the infection can harm the unborn baby, and that some women were unable to have babies as a result of this infection. So one woman says, for me, when I was pregnant, I had a miscarriage all the time. I was already in my 8th month for my first child, and then in my 7th month for the second. So really, really harrowing experience to have. The women talked about how the infection affected their sexual lives and partnerships. So some women described the pain during and after intercourse as unbearable, which often led to conflicts with partners, and partners finding other sexual partners, or even separation as a result of not being able to engage in sexual relationships. And some women were also really fearful of infecting a partner with female genital schistosomiasis. And women also reported a profound impact on their mental well-being as well. For example, hopelessness or fear of death, and also a general feeling of life just taking a wrong turn. And many women reported that they were not talking to anybody or denying the disease to avoid stigmatization. And there's another quote that I found really quite telling. I did not complain to them. I handled the situation on my own, and the people I live with didn't say anything. They were silent, because even if you complain, nobody will help you. So, and just a very few statements on the health-seeking and coping strategies. So the women in the study were hesitant about seeking healthcare, some because they were afraid of medical procedures, and others were worried about the impact that a disclosure of a diagnosis might have on their life within the community. There were some positive outcomes as well, and really relating to that very study. So the women in this study who talked with other women about their experiences felt some relief through mutual support, and I suppose that is a really good outcome of the study. So to conclude, really, I think this study gives us a really rich narrative of experiences of women that are affected by female genital schistosomiasis. So these women suffered from significant impairment of genital and urinary functions. The women had reported negative impact on their sexual life, their personal relationships, and the relationships within their communities. They were also affected in their capability to work and earn a daily living. And the stigma associated with the infection resulted in a negative self-image and social exclusion. I could spend a long, long time giving you more information, but I think I'm just going to have to, I'm just going to have to cut it short. The data are really, really rich, and the women's statements were so powerful, and it really made me think. And well, maybe if you have time, you can have a look, read yourself. It's quite an accessible paper because there's not complicated statistics to wade through. It's quite narrative and descriptive. So I think, read about it yourself and maybe learn about this neglected form of schistosomiasis. And I was kind of thinking, I can't help to think that this is a neglected disease in large part because it affects women, particularly poor women in poor settings. I hope, I don't know, maybe that is a cynical view, but I think that's how I feel. And I think for me, the most important take-home message from this paper really is how important it is to give women a voice, women with female genital schistosomiasis, but also with other infections, parasitic or otherwise. And maybe that can open doors to reducing the stigma and social exclusion, and thereby maybe the women will be more likely to go and seek help, go and see a doctors, and help more women to access diagnosis and treatment.
So, Christina,
so that's me.
Is this a risk for tourists who go to these regions at all?
Absolutely.
Probably. I mean, it could be. I don't know if anyone has looked at. I don't know. Maybe Daniel, I haven't seen any papers on female genital schistosomiasis in traveling in tourists. So I don't know, but it would be if you become infected with schistosoma hematobium.
Yeah, I mean, one of the things I would say is that, it usually tends to be a significant amount of exposure. So it's not common in travelers.
Okay. Yes.
The really tough thing, so I'm glad you brought up this paper. It's actually a paper we discussed on the infectious disease podcast as well, because I think this is a subject that is neglected in many ways through education. As we saw here, most of these women had no clue how they got it. Some of them even had the idea that maybe it was their own fault, some sort of sexually transmitted, they're worried they're going to sexually transmit it. Just the narrative, I think, is really compelling. I mean, women are just describing in the study unbearable pain, similar to someone touching an open wound, and that being an experience that they're having while they're trying to engage in sexual relations with a partner, and then they're worried that they're going to infect the partner. They themselves are not having a positive experience, actually are finding it quite painful. And then some women then ending up in a really difficult situation because that partnership falls apart because they have this infection through no fault of their own. Actually, one of the first, when Dixon and I first discussed the update to the parasitic diseases textbook, at that point in time, female genital schisto was not actually even addressed in our textbook. And it was actually Peter Hotez who was, I remember one of the first emails from Peter Hotez is like, where's the whole section on FGS, which I applaud him for recognizing that. But these women aren't aware how they get it. If they're not aware of how to get it, they're not aware how to prevent it. They're not aware what it is really, so they don't understand that there is treatment. Really, this is something where, it's education, it's communication, it's letting these women understand. And I think that, I hate to say, but I probably agree with you, Christina, it's probably because it's a woman's problem, right? And that is, unfortunately, often results in neglect lack of education, lack of communication, something that isn't being talked about. And I think we should feel more comfortable asking women about their sexual health, and if there's problems, being aware of it. Both 50% of the population. This is very much a neglected tropical disease.
Also.
I thought was also quite really revealing, I was maybe not so aware of, is that maybe also in the medical professions there isn't as much awareness of this infection as there should be. So there's education of women, of communities, but there's also really education of healthcare professionals. When women come in with gynecological problems and they would like to discuss their sexual health with a healthcare professional, is maybe not something that they necessarily, that's maybe not something that's on their radar. So education could probably change a lot if healthcare professionals were also more aware of this disease.
All right, thank you, Christina. Dixon, tell us about
Vincent.
tsetse flies.
Okay. I'll tell you something about tsetse flies. The paper that I read across recently, and this in Science magazine, it just came out. They've announced the discovery of several volatile pheromones that tsetse flies use as attractants during the mating period of a tsetse fly. As all insects, as you must know, produce chemicals which they then store in their bodies until the mating time arrives, depending on their maturation rate and things like this. And then they release them in the air in order to attract a mate. And Drosophila does it, which is a fly, and mosquitoes. Actually, mosquitoes don't do it. At least as far as I know, they don't. But the housefly does it. Horseflies, tabanids, all of the more robust flies have a pheromonal system, and it's well recorded, and they've identified molecules of interest and pursued those down into the neurological origins of the signals that are received from the pheromone itself in order to get the insect to do something. But nobody has come up with anything for Glossina, and there are 33 species of this disease transmitter throughout Africa. They live in both West and East Africa. Now, I must say that there are two kinds. There's one called riverine species that live near rivers, along the banks of rivers, and they're in dense populations. There are hundreds of thousands of tsetse flies per square mile, basically, of these riverine situations. Whereas in East Africa, the tsetse flies are distributed throughout, let's say, the grasslands and the savannas of, let's say, the Serengeti, where you might find one tsetse fly per mile of territory. So the riverine tsetses don't have a big problem finding each other, but the East African tsetse flies must use some system in order to find each other, in order to successfully mate, and they do. So this group, and I will now mention the authors because there are four of them: Sima Ibrahim, Hani Dweck, Brian Weiss, and John R. Carlson teamed up together to produce the results that I'm about to summarize for you, because there isn't really much time to go into the details of the actual how did they do it. But it started out with a simple test. They put a female tsetse fly in a test tube that hadn't mated yet, and combined it. By the way, you can colonize this organism, and so they've got colonies of various species, and the most common ones, the Glossina morsitans and the Glossina fuscipes, 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 are the main disease transmitters for both cattle and for humans in Africa. So they have colonies of these things. So they put a male and a female together inside of a test tube that had never mated before. And it was all they could do to get them to separate, because they remained attached to each other for over an hour. So they did the same experiment, except this time that doesn't sound like much of an experiment, but they then took a mated female of the same species and put it in the test tube, and then followed that up with a male that hadn't mated yet. And the male just absolutely didn't know what to do. It just sat there. There was no exchange of looks, and then from across a crowded room, and then a collision in the middle. The flies had no interest in each other whatsoever. And the same experiment was done when you tried to do the cross species of an unmated female Fuscipes and an unmated morsitans, and you put them in the same test tube. Again, they don't have interest in each other whatsoever, because they're two different species and they produce two different sets of pheromones, presumably. All right, so that was their original observation, and everybody who's raised these things knew that, and so they proceeded to the next step. But the next step was quite fascinating, because they actually took unmated males and unmated females and placed them in a solution of hexane, which dissolves, of course, all the fatty acids and the organic soluble material, and then they dried it down, and then they brought it up into a smaller volume, and then they put it into a gas chromatograph with a mass spectrometer to see what kinds of things were available that might be considered to be pheromonal in nature. Now, they had data on one compound that had been described many years ago, which was quite large. It was like 36 or 37 carbons long, so not volatile much. So they called that one a contact. They had a term for this, a contact pheromone. I'd never heard of that before, but probably wasn't being used for the East African varieties, but maybe it was used for the West African varieties, so that they could tell whether or not the female had mated or not, and if she hadn't, then maybe we should get it on to produce more Glossina. At any rate, this extract contained lots of interesting compounds, and they have beautiful diagrams that say exactly what they did with each peak that appeared differently. The peaks that appeared differently were the peaks in non-mated versus mated flies. And the patterns that they got were, you look at those gas chromatographs and you say, how could they actually pick out a peak that I can barely see? I mean, they have a very nice graph in I believe it's 2C. I think it's the chemical formula for each of the fatty acids that they extracted are numbered 1 through 19. And when you get about halfway down the list, the volatility of the compound can be excluded because they're too large to volatilize. So they narrowed it down. They started at the bottom end, at the lowest molecular weight fatty acid, and they worked their way forward. And right away, they discovered something that had an effect on mating behavior of Glossina, and it was called methyl palmitoyl or MPO, and they discovered another related compound called methyl palmitate, MP as they're referring to, then finally a methyl oleate. All of them fatty acids and methylated, of course, and you can now imagine with 33 different species of Glossina, each of these fatty acids can be modified to fit the tailored needs of these various species. So in this case, the ones that they were looking at were mostly used to look at the mating behavior of Glossina morsitans. And they did some wonderful electrical stimulation of their antennae, and they looked at the various sensilla, and the sensilla are neurons, and the neurons have various functions, of course, that they can pick up. They can see sound. They can see sound through their antennae. They can pick up vibrations and translate them. So they have a lot of sensilla to go through. But they eventually found out which ones were important, and they tested them using these three compounds. And they either got a compound that turned it on, or that when they applied the compound to the surface of an even different species, they called it perfuming. They got C. morsitans to try to mate with the opposite species that I mentioned before, the I'm sorry, I'm blocking on the name right now, but I'll go back and look at the notes. The
Fusippes.
Thank you, Vincent. Thank you. Fusippes. Now, Fusippes, unmated Fusippes females, perfumed with MPO, resulted in a mating behavior which doesn't exist in nature, but it sort of verifies the fact that they have identified something that the male will respond to, no matter which species of organism, or even an artificial fly that they created by tying a knot in a string and hanging it inside of a test tube, and that knot was about the same size as the tsetse fly, and they would apply things to the knot and see whether or not even the dummy would serve as a mating object that they could then use in their analysis of whether these were valid or not, in terms of whether the insect was programmed to receive them and to do something. In the end, they stayed with these three all the way through their experiments, and they did a lot of different things to prove specificity, including reversal of mated versus non-mated males and females of both species. And then finally, at the end, they conclude that indeed, looks like Glossina morsitans and Fusippes have volatile pheromonal categories which induce three different types of behavior. One is that it causes the fly to remain a long time on the female, and that was called a pheromone, which my show notes are not as good as yours, Vincent, and I'm having problems finding all these conclusions because the paper is so extensive that it goes into a lot of detail about the interpretation of all of these wonderful chromatographs that they ran. But eventually they had three different behaviors that they were measuring. And so increase in copulatory time, that's a linger longer love compound, a compound which attracted them to begin with to the object, and a compound which altered their response while they were mating to make sure that the mating was a success. Are these, in the end, in their discussion, they talked a lot about the use of these, and they conclude with a sentence: our results suggest the possibility of using tsetse fly odors in combination with long-range attractors to host odors for controlling tsetse flies and disease spread. So right now, they have artificial cow breath, which is a very, very attractive odor for tsetse flies. And they have invented this cow on wheels that they roll through the savanna of East Africa. And for miles, this breath comes out of the artificial cow. It attracts the tsetse flies to the object, which in this case is painted up like a zebra, and the tsetse flies home in on the source of the cow breath, or in this case the zebra breath, but it's really cow breath, and they get into a trap that they can't get out of.
Wow.
But now, if they wanted to couple that with this pheromone, the one that causes them to linger longer love, they would never even attempt to leave the domain of the trap itself, because this one of these, the MPO, has a remarkable effect to actually allow them to remain in a mating position for over an hour. I found that really remarkable. So I'm not sure I did justice to the science of this article, because there's a lot of detail here that really requires your attention. How many carbons were in the non-volatile, or it was not a contact pheromone, the name of which is 15-19-23 trimethyl heptatriaconitane. That's a mouthful, and you can't just go around saying that every day, with the relatively short compounds that they were dealing with. So they think that they have discovered something brand new, and they think it has practical application. And I hope they're right, because we are in need of a solution to a problem of controlling these vectors, not just for people, but also for their cattle.
So you think they may use these as attractants, as you say, in these artificial zebras or whatever?
Yeah, well, it depends on how you distribute these. And, I could imagine a device which actually has a fan associated with it that would actually create an artificial current of air that came out of this to distribute it in a better way, because the volatility of a 37 versus a 16 carbon atom molecule is large, but a 16 carbon molecule is still pretty large when it comes to volatile compounds.
So can you make an impact in an area with just having these decoys around? I mean,
yeah, they do. They actually
really?
do. That's the reason why they still use them. Yeah, they're quite good at eliminating tsetse flies from a tourist zone in game parks, for instance, to make sure that there are no tsetse flies in the area. I mean, when you eliminate one, you've cleared a square mile's worth of savanna. So imagine you come back with 20 tsetse flies, and you say, well, that's a lot of territory, right?
Yep.
Yeah, that works. It actually does work. But it's an artificial cow breath. It's got a methane component to it.
It just sounds wonderful.
It does, doesn't it? But to know that there are people out there working at this level,
yeah, it's cool,
trying very hard to molecularize the approach that, by the way, commercial crops are attacked by various kinds of insects, and many of them have much shorter pheromonal molecules than the one I've just described for you. And those have gone into practical production. So what they do is they flood an entire cornfield with the pheromone for the corn borer, and the mating doesn't occur because they don't know where to go. Yeah. There's no direction to the signal.
Cool.
And that's what they're hoping for, something like that here too. So maybe if they broke down the portion of the molecule that was unique to that species and attached it to something more volatile, maybe that would be an approach that they could try to use. I don't know.
No, it's a cool paper.
I'm thinking of I want to make a tsetse fly repellent, because the other side, which I thought was interesting. I mean, yeah, I do enjoy the big, smelly cow traps that they wheel around. And it's been interesting over time to watch the evolution from those traps, right, where they just painted the dark underbelly to the machines that they drag around.
Right.
But what I thought was interesting, right, was when they actually discovered that when you infect a female so a trypanosome-infected
Oh,
female,
yes, I forgot to mention
the
that.
males, they got no interest.
That's right.
And they identified these 21 small volatile compounds,
which
which are almost like a repellent thing. And so I'm thinking, we got our spray repellent. I'm going to spray me with the 21, repellent, so I don't get, because getting bit by a tsetse fly, it's basically like a horse fly. It hurts.
It's painful. It's very painful.
I mean, and, not only do I not want to suffer any pain, I also don't want to then, get the sleepy sickness.
That's right. Yeah, I forgot to mention that, but that's important because it has survival implications for the fly as well. The fly doesn't do as well. And I believe also there was one statement in there saying something that reduced the number of organisms that they could transmit also, but I don't remember where I read that.
Interesting. Yeah, they did 20 trials where they tried to mate, the males, and they gave them the option of mating, with an uninfected versus an infected female. Never are they going with the infected female.
That's
and then
right,
they
exactly
identify these volatiles, which I'm gonna patent and then spray on myself.
Well, they probably overwhelm the system that's so sensitive anyway because of there are 33 different kinds of pheromones. And I'll just give you the opposite example here. The Luna moth, I learned this from somebody studying Cecropia moths up in Harvard. His name was Carroll Williams, and he was a very famous entomologist that worked alongside people like E.O. Wilson, et cetera. And he mentioned this to one of our small groups that we were there for another reason, and we were listening to him regale us with his insect stories. The Luna moth produces a pheromone that can attract males from 5 miles away. And that's through a densely forested area, too. So it's incredible that how sensitive, and if you take a look at the Luna moth's antennae, they are enormous. So that's what I'm saying. They're really keyed into their environment, and they've evolved some remarkable systems for communicating. And this is one of them.
Thank you, Dixon.
You're welcome.
All right.
Thank you, Christine. I enjoyed that very much also.
Now, it's your turn to give us a case, right?
Yes, I have a case with you today. So, this case was shared to me by my former student on my diploma in tropical medicine and hygiene course, Professor Eyal Lechem. He's the director of the Institute for Travel and Tropical Medicine at the Sheba Medical Center in Tel Aviv, and also an associate clinical professor at Tel Aviv University. So this is the case of a new case. It's a case of a 24-year-old male who presented to the emergency room at the end of February, so quite recently, with a 4-day history of fever, which started 3 weeks after he returned from a long trip. So on admission, he reports a daily fever of up to 40 degrees centigrade. I think it's 104 Fahrenheit, something thereabouts. He also mentions an itchy rash and a dry cough. He was traveling in India during October of the past year. Then from November to early January, he stayed in Papua New Guinea, from where he traveled to Thailand, returning to Israel in early February. So a long trip, and we learn a little bit more about his travels. We don't know much about what he was doing or what was happening while he was in India. But when he was in Papua New Guinea, he says he was hiking in the jungle. He was bitten by countless insects, and he also reported finding leeches attached to his lower legs. And one insect bite on his hip took a while to heal. He also said he was swimming in many different rivers. Then in Thailand, he says he received a 5-day course of doxycycline for a febrile illness, which resolved after treatment. So when he was traveling, he says he didn't have any unprotected sexual encounters, but he says he has been eating street food and just on a regular basis. He had received pre-travel vaccines, and when he was in Papua New Guinea, he took Malarone prophylaxis daily, and discontinued that therapy a week after he flew to Thailand. On physical exam, he's alert and oriented. His vitals are normal. The examination is unremarkable, except for 3 cropped vesicles on his penis, which he says are itchy. And the examination also revealed an insect bite on his lower lip. Hip, not lip, sorry. His white blood count and differentials are normal without eosinophilia. His hemoglobin is 13 grams per deciliter, which I think is
pretty good. That's
almost
pretty good.
normal. And his platelet count is lower than normal, with a count of 100,000 per microliter of blood. So, got a few questions really for our listeners. So firstly, what's your diagnosis, and what tests, or what's your thoughts, and what tests would you like to order to confirm your suspicion? And we would like you to be as accurate as you can be when you're identifying the parasite causing this man's symptoms. So there's maybe a little hint there. And then we would like you to think about special considerations that you need to think about for the treatment of this man. And that's the case. So
he's done everything that you're not supposed to do.
Correct.
I suppose he was having a fantastic time.
He's got bitten by insects, he's got leeches, he's swimming in rivers, he's eating food.
Leeches are not a problem.
Oh my gosh.
He's been eating food.
Sounds like Daniel.
No unprotected sex, though.
Well, if you do travel, you need to enjoy your
HIV
time.
negative, right? Do you know?
I don't know. I don't have that information.
Sure his name isn't Indiana Jones?
I think he might be too young for that.
Right. This is a young Indiana. Oh, that's right.
Yeah.
23-year-old.
There's a lot going on.
Yeah, there's a lot going on, and not everything is maybe relevant. So I'll leave that up to our listeners to
Do you have it
decide.
already? You got it sorted?
Nope.
Good. Yeah.
Do not.
What about you, Daniel?
I'm going to have to think on this one. It's not an obvious slam
Got
dunk.
any questions, Daniel?
Did not. Yeah, what is it?
He usually presents, so I'd like to hear him ask a question,
No, I'm excited to figure this out. Next time you'll be able to put me on the spot before the unveil, Christina. So don't let your guest unveil until I have a chance.
And actually, we have Eyal coming on the show as well to discuss the case and
do you have a date
relevant literature. That might be useful. I think we do, don't we? I don't have my
20th of April.
Let's see.
So,
and it's going to be the same kind of a deal. So
20th of April.
5 days after our celebration.
20th of April. I'm not going to be here.
We're passed out from the TWiP 1000 celebration.
No, I'm going to New Orleans that week. I'm going to Tulane for a visit.
To Orleans.
Can you record from there, or we'll say thereabout for our listeners, just so they have a time for getting in their guesses.
It's a tough one, yeah. It's very tough.
What about the week after?
I'm in New Hampshire that week after another seminar.
Goodness.
But then we go into May, and that's, then we miss one in April, so that's not ideal.
What about one day before our TWiP 1000? Maybe we could run the case history by the audience.
No, we're not going to do that. This is TWiP, not TWiV, Dixon.
No, that's okay. We could do both. We could.
Well, we'll tell our listeners sometime towards the end of April. So get your questions in early, and we'll sort out the date.
Sort the date out. Okay. All right. That's it for TWiP 215. Show notes are at microbe.tv/TWiP. If you want to take a guess at this case, you can send it to twip@microbe.tv. If you enjoy our work, we'd love your financial support. You can go to microbe.tv/contribute. Dixon Despommier, Racaniello.org, thelivingriver.org. Thank you, Dixon.
Pleasure.
Daniel Griffin at Columbia University, Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Thank you.
And Christina Nowles at the University of Glasgow. Thank you, Christina.
Thank you. This was a lot
Vincent
of fun.
Racaniello. You can find me at virology.ws. I'd like to thank the American Society for Microbiology for their support of TWiP, and Ronald Jenkins for the music. Whose turn is it to sign off today?
Yeah, whose turn is it?
I think it's mine.
Daniel.
I think it's
Go
mine.
for it. Go for it.
You have been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP is parasitic.